Hey guys, end of week 6, another week in the books. You guys did a good job of discussing particularly carpal tunnel syndrome this week, and we also had other peripheral nerve adverse neural dynamics. So for diagnosing these things, we can't forget that the first question is, does this person belong in front of me? So, performing some level of medical screening, we'll look at this in a little bit more detail on the next slide. But don't forget that that wrist is attached to the rest of their body, right? So, some spine contributions. Make sure you're performing your spurlings and distraction, taking a look at cervical spine, maybe even thoracic spine for patients with these symptoms into the upper extremity. We'd be amiss if we didn't mention some central sensitization here. There's quite a bit of evidence for this. Bialowski, Fernandez, De Las Peñas found that there's some increased sensitivity of these folks, even that present with unilateral carpal tunnel syndrome, that they have sensitivities elsewhere in their body, opposite cervical nerve root, tibialis anterior. So we have to consider this in our nature of diagnosing these people. And then, following that nerve all the way down from root to tip. So we'll talk about that in a little bit in just a second. So for our medical diagnosis stuff, this is a chart out of Goodman that we talked about in week 1-ish, I think. So this is causes of carpal tunnel syndrome. So you can see everything from alcoholism to pregnancy, contraceptives, diabetes, and so don't forget to look at these things or to ask about these things in your subjective history. So our should have theoretically been talking about all 3 nerves this week. Carpal tunnel takes the cake as far as being the most prevalent of all of our peripheral nerve issues. But so there are several areas that could be likely for areas for that nerve to hang up. So looking at median, you've got ligament of Struthers, lacertus fibrosis at the elbow, pronator teres, anterior interosseous membrane. Remember, that one is only going to give you motor signs, no sensory. Usually those patients won't be able to perform an OK sign. Pronator teres, you can compress the mid portion of pronator teres and have a person pronate. That's pronator teres test, I think it is. And then we have carpal tunnel. In looking at the diagnostic ability of the tests that we all learned as gold standard-ish tests in PT school were, Tennell's, Phelan's, reverse Phelan's. Those didn't pan out so well in the Wayner trial that we looked at, and there certainly are some issues with electrodiagnostic testing, so don't think that is our gold standard, but it does have some flaws. Radial nerve, radial tunnel being the most common one there, and then the ulnar nerve and cubital tunnel being the most common one there. So treatment for carpal tunnel syndrome, a bit disappointing for the PT side this week. We are just not winning the war against surgery in this realm. So we looked at carpal mobilizations, neural glides, splinting, and tendon gliding, all having very modest effects, and many of those not reaching statistical significance. And so when you look at studies that compare treatment A to treatment B, and it kind of all ending up in a wash, you start to lose some of the reason that you got into doing the research. So De Las Peñas published this trial in 2015 comparing manual therapy, physical therapy in a regional interdependent approach versus surgical intervention, which surgery has a pretty high success rate for carpal tunnel syndrome, especially when the person performing that surgery is adept at differential diagnosis. So in this study, you can see just some of what they chose to show us about nerve gliding, and then tracing that nerve from scalenes all the way down, and making sure that they're decreasing the central nervous system pain circuits there, and allowing for maybe some increased nerve mobility through those areas, but changing desensitizing that area anyway. So that's been the first study that really has shown that we've had some pretty good benefit and no difference between surgery at 1 year. So next week we'll be talking about some more regional interdependence. Shout outs this week, May, Anjanette, Brandon. You guys did a really nice job and have done a consistently nice job throughout the course. So good job this week. Keep it up. Group projects will be posted tomorrow, and group project discussion will be going on all this upcoming week. So look forward to seeing you on the boards. If you have any questions or comments, you didn't get something answered, make sure to reach out to your TAs and or myself. So have a great weekend.